Hello, everybody, and welcome to today's webinar. My name is Sabrina McCarley, and I will be the moderator for NARA's webinar today. We are very excited to have Garry Pezzano here today, really presenting on a topic that is so important right now, and it is the pursuit of excellence, achieving patient centeredness. I wanted to cover a few housekeeping goals or rules before I turn it over to Garry. If anybody has any technical issues, if you could please type those into the chat. Christy is monitoring those and will be able to help you. If you have any questions for Garry, we are asking that you please type those into the Q&A. We are holding all questions until the end, and then we will address those. All participants are being placed on mute, and we are recording today's webinar. About 48 hours after today's webinar, those that are registered will receive a link to the recording as well as the handouts. We will also be placing the recording and the handouts on NARA's member portals. And with that, Garry, I will turn it over to you.
Thank you, Sabrina. Hey, folks, glad to be with you this afternoon. As Sabrina said, I'm Garry Pezzano, and I'm a speech-language pathologist, and I have been in the rehabilitation field for 30 plus years now and enjoying an amazing career. Have held leadership positions with some national providers, have worked internationally, and through it all have been really in pursuit of excellence. And right now, I think is a very good time to be having a conversation about a path of excellence. Lots of conversations about pandemic fatigue, folks really wondering about their place on the interprofessional team. Lots of challenges from a reimbursement standpoint, especially if you're working in the Medicare world. And as I said, I think that's the perfect time for us to be centering ourselves and having a conversation about who are we right now as clinicians, and what is our responsibility, and how is it that we support each other, and what is it that we do as clinical leaders to inspire the spirits of clinicians. So that's what we're going to talk about today. It really is a personal pursuit of excellence. And really, that path has been trying to achieve true patient-centeredness. And I'm hoping at the end of this 45 minutes that some of you will share a little bit of your journey as well. That's really my favorite way to spend my time talking to clinicians. So over the next 45 minutes or so, we're going to consider the meanings of patient-centeredness. And when I say meanings, I use that word really to say that patient-centeredness doesn't necessarily mean the same thing to all of us. And it's important to be using the same definitions if we're going to have a conversation. And then we'll discern one's well-being from an objective health rating. It is true that your well-being is not necessarily very well described by a list of diagnoses. And then we'll explore the 4M's framework for evolving an age-friendly health system. Part of my journey has taken me to discovering the 4M's developed by the Institute for Healthcare Improvement, and I'm excited to share that with you. And then how we can apply the 4M's through intention, and in that vein of being in pursuit of excellence. So let's get started. My story starts back, I guess, early 80s, when I was just, fully licensed as a speech-language pathologist. And I attended a course at Columbia University. It was, the course was really on managing dementia and dementia care. And I was a brand new clinician, and I quite frankly didn't know what I didn't know. And I attended this conference, and I was understanding what the speakers were talking about in regard to plan of treatment. Very specifically, I remember they were describing working with a patient who had dementia and anticipating the progression of dementia and laying some foundational behavioral patterns in place. The one was about taking medication, so that at the point that the patient was anticipated to be no longer cooperative, that there would be a system in place already. And I raised my hand and I explained that I understood the plan of treatment, but I didn't quite understand how it is you figured out as a clinician that that's what you should be working on. Well, the speaker very abruptly told me that I should just be a clinician and didn't answer my question. I was embarrassed. I left the conference early, but it really sparked in me the work to dig in and understand and feel what it meant to be a clinician. And that really kicked me off on my pursuit of excellence. So I learned, in school to use objective tests and measures. What I really needed to discover as a practicing clinician was the consideration for residual functional capacity and figuring out what was very specific to that patient, the most one can still do despite limitations. And that's very, very personal to the patient. And you must know your patient. And that needs to be part of not only your formal assessment, but your informal assessment of the patient. And then to engage with the interprofessional team, because being a speech language pathologist, to meet the needs of my patients, I very soon learned that I was going to need to rely on nurses and physicians and physical therapists and occupational therapists and respiratory therapists. So I began to discover really what that meant to be a clinician. And then it really brought me to asking the patient and asking the patient family or caregivers, because they held a wealth of information and they could lead me to what is it that we should be working on if this is our starting point. So what I discovered it meant to be a clinician was not only to do that assessment and to dig deeper for the information, but to treat and teach and advocate. So I returned to see these speakers about 2 years after that fact and thanked them for the path that they set me on. And ever since then, I've been on this journey, this pursuit of excellence, as I call it. Key to success as a clinician is really to understand what patient-centeredness means. And here's some work done by Garry. It's actually a literature review of patient-centeredness and looking at definitions of patient-centeredness. So referring to respect for patients' values, preferences, and expressed needs, coordination and integration of care, information, communication, and education. So on clinical status, progress, prognosis, and also on the processes of care. And then looking at self-care. So these are definitions largely come from, I would say, the nursing discipline. And they go on in the literature search to include in this very broad definition of patient-centeredness, looking at physical comfort, understanding full well as clinicians that we need to manage pain, because that really is going to be critical to someone's ability to recuperate, to rehabilitate, and to really enjoy their lives. Emotional support and alleviation of fear and anxiety, involvement of friends and family, and that involvement being, involvement in decision-making and as caregivers, and also considering the needs of the family. And then the final part of closing the loop of patient-centeredness being that transition and then continuity, so that what we are able to help the patient achieve in therapy is something that they carry over in life. And I'm sure that none of this is a surprise to you, because these have been parts of our definition of patient-centeredness. But that definition has evolved. So here's a definition from Don Berwick, and Don leads the IHI Institute for Healthcare Improvement. He's absolutely brilliant. If you've not read Don's work or have seen him, you should really go ahead and seek him out. And what Don speaks about in regard to patient-centeredness is the experience of transparency, individualization, recognition, respect, dignity. I'm going to just move these pictures over. And choice in all matters, without exception, related to one's person, circumstances, and relationship in healthcare. So this definition begins to bring the patient in more as an active member. And here is one on person-centeredness, because the terms are used interchangeably. Supports people to develop the knowledge, skills, and confidence they need to more effectively manage and make informed decisions about their own health and healthcare. It is coordinated and tailored to the needs of the individual, and crucially, it ensures that people are always treated with dignity, compassion, and respect. You can see that there's similarities here, but in my own personal practice, this is the one I most attach myself to. I find it interesting that it talks about supporting people to develop the knowledge and skills and confidence they need to be full participants. This is significant. I'm thinking back when I first started treating, and if you could envision a model, we draw this model, write the word patient in the center, and all services around the circumference of the circle, meaning that all activity revolved around the patient. This here, what we have in front of us, at 2014, you could say definition, is one where we really engage the patient. And we're understanding that makes the biggest difference in the world. If we can teach people to be part of their personal health plan and part of their recovery, we get better results. So when we think about patient-centeredness, one of the things that we realize is it really depends from whose perspective are you talking, right? And there was some work that I read, a study done on perspectives and perceptions. And what they really came to was that as health professionals, we have a definition of patient-centeredness, which is different from the layperson's or the patient's definition. So as health professionals, what they discovered is the definition has more to do with a view in regard to communication skills in terms of, as healthcare workers, we're explaining and eliciting information, and not necessarily in terms of shared decision making, but we're doing a lot of sharing of information. From a clinical leadership perspective or managerial stakeholders, it really is seen or thought of as customer service. And what does it mean to provide excellent customer service? And what's most interesting about this and most important about this is what the patient thinks patient-centeredness means and should mean, and what their experience should be. And that view is in the context of a social or whole person model of health at the level of patient involvement in planning and delivery of services, right? And we have to emphasize that, the patient involvement in planning and delivery of services. So I really do believe that this all matters. It matters because if we are to be patient-centered, and our practice is to be patient-centered, and we truly are in pursuit of excellence, we need to consider this from the patient's perspective. And the expectation is that the patient is taught how to be the most active member that they can be in their own healthcare. So I just love that, and I was really happy that I came to that in my own practice. Very much related to patient-centeredness and the patient's involvement in patient-centeredness is this perception of health status. And I say perception. One could say, Well, health status is a fact. There are hard facts around it. There's science around it. There's diagnoses. There's medicine. But I'm not so sure about that. So I had my own personal experience where I was going for a physical, 50 years plus now, right? And going for a physical, and I was asked to fill out this health survey asking me how healthy I am. So I'm going to share too much information with you. But if you're a friend of mine and you're on the line, then you're used to this because that's what I do. I share too much information. So I'm thinking about my health status and I'm thinking, well, I have a hypothyroid. I've got ulcerative colitis. You know, everything's managed. I've got sciatica. My gosh, I sound like a mess. So I started asking people. I said, what would you write? And what really made sense to me was they came back and they said, well, how do you feel? I said, feel really good. He said, well, then write you feel really good as your health status. And it really does make a difference. It has to do with your outlook, but your outlook plays so much into how you're going to live and how you're going to feel ultimately. So let's look at this. This is really some definitions around health status or being healthy. We're going to take a few looks at this definitions around this. So Rowe and Kahn, they put out this definition that health is really the low probability of disease and disease-related disability, okay, high cognitive and physical function capacity, and active engagement in life. It's a tall order, right? Low probability of disease and disease-related disability. We know people who are suffering from diseases, and we know that you know, when they can accommodate, they can do well. Here's one from the World Health Organization. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Okay, well, you turn 60 and tell me if you could live with this definition, right? Stringent. Here's a definition for you. Health status includes aspects defined by the individual, and its meaning reflects the individual's ability to adapt to their environment and manage their well-being. Now, here's a definition of health status that I can live with. And this is the one that I really believe serves my patients the best. I'm treating people who are dealing with disease. They're dealing with disability. My role as a clinician is to instill hope, right? To instill hope and create new goals for yourself in a situation that you never had intended. You can only do that when you begin to consider your health status as more than disease or absence of disease. Here are domains of well-being that we know are critical, right? It is physical status, psychological, social. These all play into well-being. Well-being is a subjective term, right? It describes self-reported general life satisfaction and the positive and negative emotions associated with health status. But it does impact the way we live. Well-being is subjective. It's personal. It's your own outlook. Here are the determinants of well-being: your level of physical activity, perceived social support, stress and stressors, depressive symptoms and loneliness, and a sense of purpose. All of these things are going to impact your well-being. Why do I bring them up here in the pursuit of excellence? It's because as clinicians, we really do need to consider how it is we're focused on the patient. Are we practicing in a patient-centric way? And are we considering the patient's perception, their health status, their overall well-being? We really need to. It's going to impact how successful they can be in therapy and how successful they can feel in life. The psychological well-being in older adults is characterized as the ability to deal with life situations, to have and maintain positive and closer relationships, self-acceptance of both self and others. These are the people who are going to report that they have a better health status, that they're feeling better about themselves, that they're feeling better about life. And predictors of high psychological well-being for older adults include social support, physical activity, spirituality, and the higher socioeconomic status. So social well-being has a significant impact on the health of older adults. We know that physiologically, it has a positive effect. Your attitude, your outlook, your state of mind really affects you physically. We know that already. So the components of social well-being are really about integration and contribution. The fact that you are contributing, that there is coherence, you're actualizing and you're accepting your state. So all of these things need to be considered as clinicians if we're going to take on this role of supporting people through the process. Excuse me. So people who feel healthier, social relationships are very important to them. They're an important indication of quality of life, with those who have negative social relationships reporting worse quality of life independent of disease state. This couldn't be more true. I remember doing some research looking for a pathway beyond the pandemic and pandemic containment. And I read a study that was done that people who believed that they had good, solid, meaningful relationships had less depressive symptoms. And it didn't have much to do with the frequency of socialization or contact they had with people, but it had to do with their perceived quality of the relationships that they had. And as you would expect, people who believe that they didn't have close relationships or meaningful relationships, regardless of how much social interaction they had more depressive symptoms. This is important. Think about our patients and who they're coming in contact with. This relationship we have with our patients really is an important one. It's a sacred one. We have time that we spend with patients, and we have the ability to make a real connection and engage them in a meaningful way where we can provide care. And through the work of really revitalizing after pandemic containment, it's something that really focused a lot on, especially with other folks on the interprofessional team, and especially in the skilled nursing facilities with our CNAs. Great opportunities they have all day long to be making really good connections with people, and it winds up making the biggest difference in their lives. So when we talk about this perception of your health status, this study really pointed out something very interesting. It refers us back to that definition of Rowe and Kahn. I'm going to remind you of what that definition of health status was. The low probability of disease and disease-related disability, high cognitive and physical functional capacity, and active engagement in life. That was their definition. So what this study showed is, if you use that definition that relies so heavily on disease state, disability associated with disease, that only about 15% of the population of the octogenarians that they surveyed, only 15% of them really were considered successful agers. However, When you add in the psychological and the social well-being factors, that number goes up to 62% successful agers of that same population. That's why it's so important that in this pursuit of excellence, that we are not only considering the medical, but we're considering the psychological, we're considering the social. And that's really what brought me to the 4 M's. So the 4 M's are a framework for evolving an age-friendly health system developed by the IHI, as I mentioned before, and Johns Hopkins Hospital. And they did the work around this framework, and it's simply focusing on these 4 elements: what matters most to the individual, medication, mobility, and mentation. The reason why I was so excited about this is because everything I had learned up to this point seems to be covered in this framework. And if we can implement this framework, meaning I could implement this framework within my own practice, if we could do this within departments, if we could do this within practices, within facilities, within interprofessional teams, we really hit on all of those key factors that make a difference in a person's life, truly being patient-centered, really getting at what's most important to people and what makes the biggest difference in their life. So what I'd like to do is, I'd like to take you through this framework and look at how it is you go about implementing it. And we'll stop on parts that I think may be of more interest to you, or we talk about a little less and maybe want to spend a little time on it, but let's start going through it. So in applying the 4 M's, you take each one of those 4 M's and you engage, you screen, and you assess in that area. And you do that on a regular basis. And we'll get to that, but it's not, one and done. Situations change, people's perspectives change, and their needs change. So you repeat that. And then it needs to be documented so that it's part of the plan and that you're communicating it with the interprofessional team. And you're actually using this information, this critical information, as part of what it is going to be the personal health plan for this individual. And then you need to act on it. So let's go through some of these. When we look at what matters most, that is all about knowing and honoring the individual and aligning the care with the health outcomes and the care preferences that they have. I remember a couple of experiences that I had, personal experiences, family experiences. My mother suffered from pulmonary fibrosis, and it was very debilitating. And, as any of us would do, what do we bring physical therapists and occupational therapists and respiratory therapists, into our family, and we want the best care for them. And I can remember having a conversation with my mother, and the occupational therapist, and I was talking to my mother about how, you can work on, doing some cooking and getting back to, the light housekeeping, only to have my mother tell me that she was retired. She didn't have an interest in cooking anymore. And she would let us know what she wanted to do. And she had a list of things she wanted to do, but it was nothing that I put on the list. I assumed I knew what she wanted. So important to have that conversation about what matters most. Determine the right questions for aligning care, and you need to ask them again and again. They need to be just part of what we do. It needs to be systematized. For instance, if say we're in the skilled nursing setting and a patient is being admitted, and we ask them what's most important to them. What may be most important when they're first admitted, maybe they're concerned about pain management. Am I going to get my pain meds? And it could be that, after a day or two, or maybe a little longer, and they become more comfortable with that, what's most important to them changes, because if you've taken care of, what was most important, and, they're feeling like they can move on to the next thing, but it's very personal to the patient. So we need to ask what's most important to them. We need to consider that. We need to ask on a regular basis. We need to report it. We need to make sure we share that information with each other, and we need to make sure that we use it. We need to align the care plan with what matters most to the patient, to the person. Another one of the M's is medication. So what we're called to do is use age-friendly medication that does not interfere with what matters most to the patient, does not interfere with their mobility, and does not interfere with their mentation. So what was outlined in this, along with this framework and the implementation, is a check for medications that you screen for on a regular basis, and they have a list. And of course, you add to this list. So we as clinicians are not prescribing medications, but we certainly are part of the interprofessional team. We could bring that conversation to bear. We could also be a resource in this realm, and we could be advocates for educating and deprescribing. And one of the resources that you may be familiar with is the AGS Beers Criteria. So the AGS Beers Criteria are lists of certain medications that are really worth discussing with health professionals, because they may not be the safest or the most appropriate options for older adults. We know that, unfortunately, much of the research on pharmacology is not necessarily done with an older population. And there is a difference there. The medications could be metabolized differently. There could be different unexpected reactions. And there are 5 lists when you go into the Bears resource. They include, they describe specific medications with evidence suggesting that they may be, avoided by most older people, avoided by older people with specific health conditions, avoided in combination with other treatments, and used with caution because of potential harmful side effects. And the doses need to be considered when you're working with an older population. So I would recommend this resource. If you haven't accessed it before, you may want to go take a look at that. I know that it's been helpful to me. And then another one of the M's being mobility. How important is having a personal movement plan to everyone? It makes the biggest difference in the world. And especially, when we talk about pandemic containment, one of the big tragedies associated with that is the unintended effects of pandemic containment, and that being the isolation and limited mobility, and something we address now, right, as a after effect. So important to have systematized, again, know the screening tool that you're going to use and determine the screening frequency, and implement a fall prevention protocol, and then identify a set daily mobility goal to support what matters most. Incorporate movement in what it is the focus is for that patient. And it should be something that the patient decides is important to them and they agree to, and it makes sense in their day. And then the fourth and final M, mentation. Mentation really associated with cognition and state of mind. So we really need to do a differential diagnosis of dementia, depression, delirium, assessment of functional status. Again, document that, educate, and support. Many of us are, especially if you're working with a geriatric population, are, very familiar with tools for assessing dementia. We're considering depression. What I have found, though, is that delirium is not necessarily identified very well, very easily, very frequently, and I have spoken to some hospital partners who are doing some really good work around identification and addressing delirium, but it also exists in a long-term care population, and patients who suffer from disease-related disability and disease. So let's take a little closer look at delirium. I'll share some of the information that I found on this. So delirium is a serious disturbance in mental abilities that results in confused thinking, reduced awareness of the environment. The way we differentiate delirium from dementia or even depression is the rapid onset within hours or within a few days. The symptoms, are not that different, but the key here is the rapid onset, and the symptoms are reduced awareness of the environment, cognitive impairment, behavior changes, and emotional disturbance. And here are some of the causes of delirium. I'm not going to read you this list. These are really all medical causes, either disease caused, condition caused, medication caused, and you could read through this list. But what's not on this list that I discovered in looking into this is delirium could be brought on by things like room changes, frequent room changes, isolation. Made a few notes here to myself. Interrupted sleep patterns. Thinking about pandemic containment, these are all things that our patients were subjected to. And it is important to really differentiate from a depression, a dementia, delirium, to identify these things and have them addressed. So many of you are familiar with the confusion assessment method, the CAM. It's part of the MDS. It's section C of the MDS. It's a staff assessment for delirium, acute onset, inattention, disorganized thinking, altered level of consciousness. So I know that many of us have gotten very familiar with sections of the MDS, in particular section I, looking at dementia and understanding our role in identifying a dementia, the degree of dementia. We know that in the MDS, that section, the BIMS really looks more at memory and not very sensitive, or was never intended to be sensitive in looking at mild cognitive impairment. So we understand our responsibility to really weighing in as an interprofessional team member on signs and symptoms of dementia. Depression being section D, also as it impacts the person's life and their ability to participate in therapy. More and more of us are becoming aware of that. Delirium is something that we really do need to consider in our role in identifying and being part of the solution, because there are complications of delirium. So for seriously ill people, it's more likely to lead to health decline, poor recovery, need for institutional care, and increased risk of death. And older adults admitted to SNFs with delirium may be prematurely or inappropriately diagnosed with Alzheimer's, dementia, or related dementias, which is serious if we get this wrong. So I would ask you to consider, what it is you're doing in regard to your focus on this, one of the 4 M's being mentation, and your role. So I was excited to really come upon the 4 M's and to get to be more involved with folks who have done a really good job of integrating the 4 M's in practice. It truly is a systematic way to evolve an age-friendly health system. What I do know it requires intention. We really need to focus our energy on it and be intentional about things like making sure that we understand and we're asking frequently about what matters most to the person, making sure that their medication is not interfering with their ability to have the fullest life that they can, that they do have a personal mobility plan, one that makes sense for them. And in the area of mentation, that we're doing the absolute best we can to make sure that we identify any issues that they're having, and we really make the referral to our interprofessional partner. And how do you go about being intentional? You need to be clear on the result you want. So when I talk about a pursuit of excellence and really looking to achieve true patient-centeredness, you have to begin to envision what that looks like, what your interaction with the patient will be, what the patient's outcome will be because of that. And you need to be deliberate with that every day. We need to be watching for that. And we need to be looking for the signs that we're making a difference in those areas. And we need to be purposeful with our time. There's lots of pressures out there about what needs to be done in a certain amount of times. I know that there are, it makes it difficult, again, referring back to infection control and pandemic containment and isolation. We need to figure out how it is we best use our time when we do have the opportunity to be with our patients. We need to be focused, and we need to be intentional about our goals and be intentional with the most important relationships we have. And I would repeat myself in saying that relationship between clinician and patient is one that we deeply value, and that really is a sacred relationship. They're counting on us, and this is how we make the biggest difference in the world. Imagine if those clinicians, imagine those practices, those facilities who had already integrated these 4 M's. Think about how differently they go through pandemic containment and isolation than professionals, places, practices that have not yet ingrained them. I really do believe that this sets us up for sustainable success. This to me really points me in the right direction of excellence. So just share with you the IHI triple aim to really simultaneously improve the health of the population, enhance the experience and outcomes of the patient, and reduce per capita cost. This really all fits very nicely together, evolving an age-friendly health system, the triple aim, and the pursuit of excellence. So thank you for letting me share my story. This is really how I go about being the best clinician that I can. Let's check our time. Oh, we went about 43 minutes. So I am going to stop sharing my screen and hand this over to Sabrina.
Thank you, Garry. That was awesome. For those of you who have questions, if you could please type those questions into the Q&A box and we will get those answered. Just a couple reminders. I know there are some questions, so I will get to those after I give the reminders that have come in. So we did record today's session. A copy of the recording will be emailed to all those that registered within 48 hours, as well as with the link to the handouts. Christy also put the link to the handouts in the chat box. So if you have the updated version of Zoom, that also is available in the handouts. We will also be posting it to the NARA member portal, and that will include the handouts as well as a copy of the recording within about 48 hours. So one of the questions that has come in, Garry, is when you talk about the determinants of well-being. I love that as an occupational therapist. I love the occupational profile, right? It's very holistic. It takes, you know, the psychosocial component, it takes the mobility component, it takes the interest of the patient, everything into kind of consideration and puts it into a great document. What are your suggestions or advice? I love that this is coming from you as a speech language pathologist too, because I think sometimes there's some apprehension out there from, you know, a physical therapist or a speech language pathologist or even an occupational therapist to really understand how do you look at those determinants of well-being and how can that easily be incorporated into an evaluation or the plan of care, because that really was part of this foundational piece of everything you talked about.
You know, that's a great question. I go back to the assessment of the patient and really understanding what is most important to the patient, because I really think that it's derived from that. I think when we understand the goals that this patient has for themselves, what is it that's important to them? What are they looking to do? And if I could relate that back to the 4 M's, you know, if you look at, you know, movement, you know, asking someone to exercise is very different than asking them what they want to do, what they want to engage in. And then it becomes our responsibility as clinicians to figure out the gap between where they want to be and where they are. And so I think mobility is an easy one because it's very tangible. You can see it, you can feel it. Think about when you start talking to someone about their relationships and the relationships that are important to them. Because when we talk about people and their relationships, I'm going to stretch here as a speech language pathologist, and you're going to correct me, Sabrina. But I really see relationships. A big part of relationships is what we do together, right? That's really what builds relationships, the experiences we have together. That is such a rich amount of information for us to have when we think about what's most important to people and trying to bridge that gap. You agree with that about the doing and the relationship?
I completely agree. And as an occupational therapist, we're getting very personal with somebody, right? I mean, when we're talking about ADLs and showering, I could not agree more with you that it's about building a relationship and building that trust. And I love the emphasis on really what is important to the patient. I can do my comprehensive evaluation and I can come up with all types of goals, but it's not going to mean anything if the patient has a totally different set of goals, or if I want to work on, you know, a certain activity such as toileting with the patient, and the only thing that the patient could care less about is how do they ensure the toilet's clean, right? So we've got to find out what is meaningful to them, and we've got to really figure out, even if you say the mobility piece, which is so imperative right now, when you look at that mobility piece, how do you be mobile outside of a typical setting or even that typical clinical setting? Most places are not allowing you to be in the gym. So what does mobility look like? And how do you engage in mobility in really all the restrictions? So that relationship, I think, is key. And I think another point that you made that's very key is it's not a one and done. It's not having that initial conversation about what is meaningful and what are you worried about and what do you want to accomplish, because that could be day one. But once you've established that trust that they're going to get their pain medication when they ask for it, that they're going to get to go to the bathroom when they ask for it, well, now they've moved on, they've progressed. And so we've got to progress with that. So I 100% agree with your statement that it is about that relationship and building that relationship.
And if I could add to that, Sabrina, you know, I also mentioned, because I feel strongly about this, is that as rehab clinicians, we do represent hope for people, right? We meet people who are in a situation they had not intended for themselves, and they have to rethink their goals And, you know, that's a process that we need to be ready to help them with. We may need to kind of like broaden how they think about their life, their capabilities. And, you know, and again, as a speech language pathologist, you know, I really believe it's essential that, you know, that our role as speech language pathologists is really to help with the communication of that, to be the model of the communication, to make sure it's happening. Everybody on the team plays their part. The patient plays their part. The family plays their part. But as a speech language pathologist, what I bring to that is, let's make sure we're talking about it and doing something about it.
Agree. Another question that I think is good that's come up is you spent some time talking about medication. And medication is so important, but I think that it's also one of the most intimidating things that we face as practitioners, because we can get this huge list of medications, and sometimes that's intimidating, and it's very easy to say, we'll see medical record. But if we don't understand the impact that those medications can have on the patient and their ability to really participate within therapy, that's limiting. But the other part of that I would like you also to maybe comment on is, I think practitioners also in that overall intimidation don't fully understand or maybe lose track, and we need to help in guidance or education and what our role is, because to your point, we're not the ones prescribing it and we're not the ones who are administering it. But you know that the opioid epidemic is still out there, and pain is still out there, and really we play such a vital role in non-pharmacological interventions. And so I think if you have any advice of how do we put that medication piece back really in front and center, because I think that's so imperative as our comprehensive plans of care to ensure that we're addressing.
Yeah, that is a tough one, but it's something that we can't shy away from. We absolutely need to address that. So let me just explain how I approached it, and maybe somebody has, you know, some good advice for me as well. The 4 M's provides a great framework, and the beginning of what I could focus on was a list that's right there given to me. There's a reason for that list. That is a list of medications that is commonly used, especially with the geriatric population. And that list really has an impact on mental status, on physical function, right? So that was a list that I could start with and get more comfortable with. Then secondly, what I realized, and didn't really realize this with my patients, I realized this with my 85-year-old father and helping him to manage his personal health plan, is when I started to test him on what he was taking and why he was taking it. I think that's critical. That's one of the things that we can do with and for our patients. You know, think about the role of a clinician. And you've got this patient who was on 5, 7, 9, 12 medications. Do they know what they're taking? Do they know what these medications are intended for? And I really found that to be a great education for myself as a clinician, and asking that question. And then I don't want to go on too long, but I do have this fantasy that I'm trying to actualize. And that is that patients are not dispensed medication, but we assist them in taking their own medication. And as we're doing that, it's, this is your diuretic. This is your, and then have them tell you, you know, people are blindly taking medications. We are treating patients and we are blind to the medications and the effects they have. And then I would say, thirdly, I probably should have put it first, but it's on the list, so I still get credit. You got to use your interprofessional team, right?
Yeah.
The consultant pharmacist is a great resource. In fact, that is their job. That's what they want to do. That's what they're expected to do. Talk to them about it.
No, I think those are great points. And I think any resources that therapists can have easily at their fingertips, it makes it easier in that understanding. I know we have just a couple of minutes left, and I have one more question that's come through for you. And I have been fully fascinated by this. And I have to be honest that prior to COVID, I didn't really think much about it. As a occupational therapist, it wasn't ever anything that I honestly addressed in treating my patients. And so I've been very fascinated by this focus of really the sleep deprivation component. And I think it's coming up more and more. We would talk about sleep in regards to, well, what time did you go to bed? What time do you wake up? If you're having problems sleeping or, with dementia, let's limit, the caffeine. But truly, that impact of the sleep deprivation and how you tied that, with delirium. And now we're seeing more of that delirium piece. So what is it that you think in regards to the sleep deprivation? I mean, do you see all disciplines playing a role in that? Do you think it's, something that we should just all be aware of? I think there's so much anxiety and there's so much going on right now within this public health emergency. It just seems that topic, that item keeps coming up more and more in conversation.
It's something that I really am committed to learn more about. And I really have an appreciation for, some of you may know Kathy Chiolek. Kathy is a physical therapist, and I know Kathy's doing some good work around sleep and sleep patterns. And I'm beginning to look into her stuff, and I need to learn more about that. I do know this. I do know that when we have an interaction with our patients, we need to check in on them, and we need to know how they're feeling, and we need to know what happened before we met with them, and we need to pass on the information. So I think in this pursuit of excellence and this working intentionally, I think that you make the most of that session and you realize that we are a piece of this person's entire life. And it's our responsibility to find out information and share it and make sure it's acted on. So at this point in my practice, I would say that's what I see my role as. And but it is something that I'm interested in learning more about.
Thank you. So that is all the questions that have come through. Again, thank you so much, Garry. That was such a great presentation, really valuable information. I think this is a great foundational presentation to kind of revamp us, right? Re-energize us, kind of refocus us with everything that's been going on in COVID-19. And a great reminder, it's really all about the patient, right? If you're a physical therapist practitioner, an occupational therapist practitioner, a speech language pathologist practitioner, a nurse, etc., we're all here every day because of those patients. So it's so imperative to put them truly at the center of everything. So thank you so much, Garry, and thank you so much to everybody, and have a great day.
Thank you.
Bye.